Mayo Clinic presents
Emergency Medicine Grand Rounds.
Hello and welcome to Always on EM, the Grand Rounds edition for April 2025. This is Venk Bellamkonda, like vancomycin if you will, and I'm one of the amazing hosts of the show along with Dr. Alex Finch, who you know I think is the better half. I am thrilled to introduce you to our outstanding recording this month, but first, we want to take a moment to thank you all for tuning in as we used to do in the past. You all are the reason we do this, and we get so much energy and joy from connecting with you, which we've had the chance to do as both he and I have been traveling a lot recently, getting to teach in a lot of different venues. I recently went to Puerto Rico with my family to be able to teach as part of the Mayo Clinic Urgent Care Updates Conference, and there I got to meet Dr. Marcela Serrano from Intermountain Health and hear about the amazing things she's doing in her practice and about how Always On has been a part of that. It made me feel really great inside, and I took away some ideas on how I might be able to help her and others and help you in general as the listeners. So I was incredibly grateful. In addition, recently, we were excited to see somebody named Aoki13. Hopefully you're listening. Follow us on Podbean. We were jazzed up about that. And then one of our colleagues here at Mayo, Bo Madsen. Thank you for following us on Podbean as well. Every single time that we get to feel your energy, Alex and I are incredibly grateful. So if you have a moment, we'd love to hear from you. Please reach out our email account at alwaysonem@gmail.com or via Instagram. Or if you pass us in the real world, pull us aside, say hi. We'd love to connect with you and hear about the amazing things that you're doing, hear about what you like about the show, what you'd like us to do differently or do in the future, anything and everything. We'd love to connect with you. So please do that. In addition, tell your friends about what you're listening to, and maybe they can be always on as well. Okay, today's Grand Rounds is by Dr. Lauren Chernick, who has been doing amazing things using digital health technology to connect with adolescent patients on sexual health topics. And although, to me personally, the interest and focus on sexual health was not an area that I'm personally passionate about, her use of digital technology could be widely applied to a lot of different things that I am interested in. And it was a kind of talk that sparked a million ideas in my mind, and I think will do the same for you. So you might want to get a pad of paper and a pen or a digital version or equivalent to take some notes, because she's about to blow your mind. Okay, sit back. I'm going to give a formal introduction of her right about now. Our guest today is Dr. Lauren Chernick. She's an associate professor of pediatrics and emergency medicine at Columbia University and is also associate professor in the Department of Population and Family Health at Mailman School of Public Health. She's practicing pediatric emergency medicine physician, board certified in both pediatrics and pediatric EM, and has a dedicated career to both the clinical care of children as well as the study of how to improve health in adolescents and young adults. She's been the PI, co-investigator, and site PI on multiple grants and has been funded through a K-23 Career Mentor Development Grant from the National Institute of Child and Health Development, as well as is the PI of an R21 from the National Institute of Nursing Research. And she's co-PI on an R21 from the National Institute of Allergy and Infectious Disease as well. And if that's not enough, one of the most impactful research programs that I'm aware of in my career is the PCARN group, and she serves as the past chair of the PCARN study network. That's the Pediatric Emergency Care Applied Network, especially focusing on adolescent sexual health working group. She ran the pediatric research intern program in her emergency department for 8 years and currently teaches 2 graduate level courses focusing on child and adolescent development and adolescent sexual health. Her specific research focuses on improving adolescent sexual health through designing, testing, and implementing innovative and engaging digital health platforms that fit into the ED workflow. As an investigator, Dr. Chernick has extensive experience with qualitative and quantitative data analysis, user-centered design, digital health, and ED-based trials. She's recently appointed the Associate Director of Qualitative Research and Implementation Science at the Department of Emergency Medicine at Columbia, and we're really, really excited for your talk on designing digital interventions to improve adolescent sexual health. Thank you so much, Dr. Chernick.
Really exciting to be here. So I brought in the topic a little bit because, adolescent sexual health is very dear in my heart. When I was creating this talk, I wanted to zoom a little bit out to give everyone a little bit a larger view of the kind of the playing field of digital technology. And then we'll zoom a little bit more in on adolescent sexual health. So as noted, I have nothing to disclose. And these are our 3 learning objectives: to review the landscape of digital health technology, discuss the iterative process of how to design and test mobile health interventions. And in doing that, I'll focus on the 3 interventions that I've built over the last 15, 20 years of my career. And then if we have time, I can highlight some other things that people are doing. And then maybe before anyone asks me a question on AI, I can actually tell everyone else. I'll answer the question before you ask it. So let's talk a little bit about the landscape. So the term digital health or digital healthcare refers to a multidisciplinary idea that includes the concept of the intersection of technology and healthcare. From a broad perspective, it can include exciting areas as noted in this graphic from the Academy of Medicine in 2022. Here they classified the various digital health tools into a dozen or so applications. It's a busy slide, but it's a really busy field. So they think about implantable devices, robotics during surgery, 3D printing and sensors and epigenetics and decision aids, which we use a lot in emergency medicine, predictive analytics, remote consults, and the list goes on. And it's important to note that AI and machine learning can really be incorporated into any of these. I like to see digital interventions as really taking 6 avenues. So we can think about our electronic health records, the alerts we get in our EMR, like sepsis alerts, or an example of research. PCARN is doing this it just finished actually, a really interesting pragmatic trial where they evaluated electronic integration of patient-reported data around behaviors dealing with STIs, and then that guided clinical decision support for providers built within the EMR. We could think of telehealth or telemedicine. So no one can really deny the increase in this over the past few years. So you could think of remote consults for psychological emergencies, or teaching to rural areas, or really just talking to our patients from home. Wearable devices, so think about tracking your steps, to those being mindful from my watch, to blood glucose monitoring, or personalized medicine. So this category really thinks what it would be like if particular data from your wearable or your phone was being fed to your provider to make informed decisions about you. And then we have mobile health apps, which I will broaden to include any of those interventions delivered from your mobile device. And I like to think of this mobile health interventions in really 4 areas. So we can think about diagnostics and clinical decision making. Think of symptom checkers for COVID, or screening for the reoccurrence of cancers, or apps that pool CT data, alerting clinicians in pulmonary embolisms in real time. We have digital therapeutics, apps that support self-management by digitalizing traditional therapies. So think of an app that provides cognitive behavioral therapy to help you in your weight loss journey. Delivering disease-related education, sorry, that's my dog, or apps that focus on behavior change. These are powerful platforms that can personalize goal setting for binge eating, or smoking cessation, or contraception use. So are mobile health interventions the answer? So the market seems to think so. Their projected value is to exceed $660 billion. There's over 350,000 mHealth apps available worldwide. Telemedicine, 70% of adults at minimum have been using it. And there's over 500 million devices in use right now, with AI and machine learning really driving personalized medicine and diagnostics. The NIH also seems to believe in digital health technologies, at least as of last year. And here you can see that there's an upward trajectory of funding for digital health technologies and clinical trials sponsored by the NIH. Okay, so now that we talked a little bit about the landscape, let's discuss the iterative process of designing and testing mobile health tools. So how do you create an effective digital health intervention? So to tell that story, I'm going to kind of jump back to 2007. This is me on my last overnight as a pediatric resident, about to finish my last 24-hour shift and about to start my pediatric emergency medicine fellowship. And it was just a few months later that my mentor at the time, and still my mentor today, Dr. Peter Diane, asked me an important question when I pondered what my fellowship project would be. And he said to me, "What do you care about?" And it didn't take me long to realize that what I cared about were all these 14 and 15-year-old adolescent females coming to the emergency department and asking for a pregnancy test. And many times we would say that they're not pregnant and that they should just follow up with their primary care doctor. And it really felt like we weren't doing anything. We really should be doing more. And I felt like we could do more. And that's really how my research journey began. Now, while I'd love to start with telling you what I've been working on over the last few years, which is sticker, it really doesn't make sense if I really start there and not tell you the story of Dr. Erica and Dr. Eric. So I knew I wanted to start my fellowship and I wanted to focus on these adolescent females. And at the time, and still now, they have very high rates of unintended pregnancy and infrequent contraception use. But I was about to start my fellowship in the emergency department, and I think everybody here in that classroom or on the Zoom right now knows that the ED is not like the outpatient clinic. An ED intervention needs to be brief. It cannot take up hours of patient time and a room. It needs to be theory-based, so based on some sort of conceptual model that increases the chance of it actually working. It needs to be reproducible. So what works in my ED needs to work in others, which leads to it being cost efficient as to make it reproducible. It needs to be accessible based on some sort of digital device that is available and familiar to the user. It needs to be patient or person-centered, tailored to individual needs. Of course, it needs to be data-driven and evidence-based. I mean, we're scientists. And I needed it to be confidential, particularly for adolescents. They needed to believe that the data provided would remain private. And I think the most important thing to an ED-based intervention is that we need to cannot impede with patient flow. In the ED, we have sick patients, we have limited resources, and any intervention that asks for provider time, which is our biggest asset in the ER, will be difficult to get buy-in. So therefore, I prefer interventions that aim to minimize provider involvement. And at the time, in early 2010s, text messaging interventions, well, those were the thing. They were positively changing behaviors, and adolescent females at the time were sending and receiving over 3,000 text messages a day. It was convenient, it was cheap, it was private, and it was really making a difference in large Cochrane reviews. So in the beginning of my fellowship, I just started to set out and improve the unmet sexual health need of adolescents in our ER, and no one was really looking at this at the time. So we just did a study of about 400 females, and we took quantitative algorithms from the public health world to calculate how many of these females were projected to get pregnant in the next year. And what we found is 1 out of 3 adolescent females in our ER were either pregnant, 13%, or expected to get pregnant in the next year due to non-use of contraceptions or using contraceptions that have high failure rates. And these females were more likely to not have a doctor and use the ER for their care, proving that this was kind of our problem too in the emergency department. So we conducted a little study, sending them to family planning clinic, and not surprisingly, we found that nobody went. And so we went back and we started to talk to them more to really understand why they weren't using any types of birth controls and what they wanted their text messages to possibly look like if we were going to design an intervention. And then we conducted a randomized control trial with these one-way text messages that in retrospect were pretty boring and not surprisingly didn't really increase contraception use at all. And at the time, we started then to think about more advanced text messaging to create something that was a lot more engaging. So there was increasing evidence at the time that personalized and interactive text messages were more effective at changing behavior than these static one-way messages that I showed you before. They can mirror elements of in-person counseling, like giving tailored advice or goal setting, and really creating this digital conversation. And the best part about it was it can be automated and therefore scalable. And that's when Dr. Erica, Emergency Room Interventions to Improve the Care of Adolescents, was born. We made a logic model of the problem, starting from the health outcome, which is the goal to decrease pregnancy, defining our behavioral outcomes that we wanted to achieve, really sketching out what we thought the intervention would look like. And then we chose specific change determinants that we aimed to affect. Our theoretical model, we used social cognitive theory. It was associated in large reviews with behavior change in terms of contraception. And we chose to incorporate the language of motivational interviewing as a way to show empathy and encourage self-reflection. We built a sexual health curriculum. So on Mondays and Fridays were these educational texts, and Wednesdays were the more lighthearted gifts. And importantly, over several meetings, we made sure that the curriculum really marched back to the social cognitive theory and motivational interviewing. And then we began to incorporate the theories of human-centered design. I'm wondering, has anyone in the room ever heard of human-centered design before? I feel like more and more people are hearing about it. It really thinks about incorporating the concepts of community-based participatory research and implementation science. Science, also known as design thinking by the design firm IDEO, and involves cultivating empathy for the user and creating these immersive experiences like to gain new insights into the problem. So brainstorming and iterating these prototypes, which are really like small pilot testing occurring over greater frequency and over shorter cycles, and allows us to validate solutions and uncover these unforeseen implementation challenges. So this time we actually went into the ER and we went into the girls' ER room and we set up the room like a bedroom. We brought a lamp and a blanket and a teddy bear and we gave them this iPad and we sent them these text messages. And we just asked them, like, give us your feedback. What do you like about this? There were many, it was like 350 text messages over all these interviews. What makes the messages good? What makes it engaging? How can we write better messages? And we found that they liked it to be direct and factual, not presumptive or preachy, entertaining, mix of formal and friendly, thought-provoking and empowering. And really, they wanted these messages to be relatable. So here's an example of one of our texting streams. We built these text messaging algorithms using branching logic. So a participant would input something into the system and it would lead to text messages that were based on their preferences. And all the messages ended with an evidence-based website. So it was a link to, for example, a video testimonial of a girl who used that type of birth control. Of note, this was kind of before chatbots were a thing. So we were trying to create one on our own. We also linked to our website, which was a repository of evidence-based websites and a link to local clinics. And ultimately, Dr. Erica became a relatable, empathetic, straightforward, and reliable virtual female doctor who sent these 10 weeks of personalized and interactive text messages aiming to promote healthy sexual behaviors and decrease teen pregnancy. First, we conducted a cohort study and the results were so promising. Like half of the girls that were enrolled actually started an effective form of contraception throughout the study duration. And then this led to funding for my K-23, where we completed a pilot RCT of Dr. Erica with girls randomized into the intervention group, watching a video and getting these text messages, and those in the control group really just getting standard of care. And what we focused on were some of the health implementation measures. So feasibility, we showed that this was feasible, that this was acceptable. Adoption is the intention or decision to use the intervention. So showed pretty good adoption. Fidelity was high. That's the extent to which an intervention is used as intended. And although our pilot was not powered to detect a significant difference between arms, because we needed thousands of patients to do that, we did not really show a huge difference between the intervention and control, although it kind of led in the right area. What we did show was that those in the intervention group seemed to move along their stages of change from really this pre-contemplation to contemplation, but we really weren't getting them to the activation stage. So what do we do next for Dr. Erica? Well, this is kind of what we've been working on now. We've received some local funding to make an ED-based app to see if we can motivate them to follow up at family planning clinic to receive patient-centered sexual health support. So we just completed the cohort and we'll soon be kind of talking about those results. So that's the first intervention. But I'm still not ready to talk about sticker because the story goes, as we were interviewing one of the females, she asked if her boyfriend could stay in the room. And his misconceptions about birth control were astounding. He gave this whole story about how he heard about the IUD, which travels up from the uterus into the brain and causes bleeding. And we started to realize that how can we expect these male partners to really support their female partners if no one was teaching them about different types of birth control? This time I knew I needed to be a little more methodological about my design and development. And many models have been published and think about how you make these types of interventions. Human-centered design with many of these Ds, like discover, design, etc., and these kind of interactive circles that you can see here, agile or lean methodology. So we started to think about this a little more and really created these 5 areas: defining, discovering, design, develop, and deploying, which is kind of a grouping of a lot of things that were already out there in the literature. So define. The first thing we wanted to do was to characterize the health program and target population, conduct a needs assessment, interview these key stakeholders, choose our behavioral change theories, describe the setting, and really think about our performance measures and outcomes. So we went back to the ER and we started to talk to these adolescent males. As you can see, I do a lot of qualitative work to really explore reasons for the way that these adolescents think and behave. And so after interviewing them, we then started talking to our key stakeholders, many key stakeholders. We went to local high schools and spoke to sexual health counselors. We dug into national health curriculums. We spoke to youth advocacy organizations, and we really started talking to different technology experts as well. We made our logic model like we did the first time. We thought about our health outcomes, our behavior outcomes, the performance objectives, like I mentioned before, thinking about the social cognitive theory and language of motivational interviewing to guide the intervention. Then it was time to discover. So we partnered this time with a design software team, which I'll talk about in a little bit. We really dug into understanding user preferences. We conducted these human-centered design workshops, conceptualized the brand, and outlined and drafted the intervention. So in this phase, we went back to the ER and we really started to talk to them about what they wanted the intervention to look like. Now, I thought texting was so great. Wouldn't all these adolescent males want a texting intervention too? But what we did, because I wanted to be open-minded, was we gave them these sorting cards. It said like app, brochure, text messaging, and we started to talk to them. And what we realized were text messages, they were going to put on do not disturb. Video games were for killing people. Phone calls, they would block us. Face-to-face, they actually liked things being anonymous. Apps, they didn't want to download them from the App Store because they didn't want them to take up their data. But a tablet-based intervention in the ER, they seemed to like that. And here are some of the themes that came out of the qualitative analysis. So the ED visit is boring. Now, could you think about how many hours of unused time your patients have in the emergency department when they're waiting for tasks, waiting for a bed? And so there's some really good data out there called the Sentinel Event Model, particularly, that says that people who come to the ER for chest pain might be more likely to stop smoking. So we really have an untapped moment in the emergency department to really think about how we can change behavior. They also said there are too many competing distractions outside the ED, but in the ED, happy to learn. And sexual information sent from ED medical providers is reliable and confidential. But we wanted to understand them more. So this time, very early on, we partnered with a digital design agency who assigned us a team of user experts and user interface designers. And we built a repository of like all these apps and websites that adolescent males used at the time. And we did these sprints. So we dug into what ED patients might be saying, might be doing, might be thinking and feeling during their ED visit. This became important as we wanted to think about the right language and also like the right colors. So for example, it's not a good idea to use red because that means danger, and there's already a lot of danger in the emergency department. They want us to stay away from those colors. We built personas of fictional characters of real users. So a 19-year-old male coming in for an ankle injury, a 16-year-old who identifies as a male who has sex with male presenting for an STI exposure, a 17-year-old presenting for abdominal pain, here with his parents. And then the design firm gave us style tiles we were able to bring back to our user and find one that fit their preferences. In the meantime, we had to write all the content, right? No one else was writing that except for us. And we had to pass it around to other key stakeholders, such as experts in the field, to make sure that what we're writing was evidence-based. And this really led us to the brand. We started to think about who Dr. Eric would be, emergency room interventions to improve the care, kind of like a spin-off of Dr. Erica. But this time, we were not just going to ask them to text into a program. This time, the intervention was going to be embedded in the emergency department experience, and we really needed to think about implementation and design with implementation in mind. So we built a journey map of what Eric could look like and where realistically and practically could fit into the ED visit, iterating multiple times with each sprint and meeting. And then it was time to design. So write and refine the content, code a low fidelity prototype, and conduct this usability testing with the end users and informatic experts. We need to consult the key stakeholders with each time and refine, ultimately leading to a high fidelity prototype. So ultimately, after doing several interviews with patients and providers, this is what we landed on. So this is kind of the landing page over here. It starts with kind of a brief explanation of what Dr. Eric is, and then goal setting, which asks open-ended questions so the user can better explore their own feelings and goals for the future. Then there was the condom chapter, which included true and false questions, which the answers were then explained, as well as a condom usage puzzle, which we borrowed from the CDC that has to be placed correctly in order to move on. You can see over here, there's even some gamification where it counts up how many they got right. The next session focused on decision-making, using a story about Ray and Kayla. It posed questions exploring how he should respond to some of the things that she might ask him in order to reinforce evidence-based recommendations and sexual health facts. Next was a section on female birth control that I thought they wouldn't really want to know a lot about, but it turns out in the interviews they actually did want to learn a lot about, including the side effects. So here they can click on any individual birth control method and learn some information about it. And in this last one over here, birth control combinations, they can pick one or two methods and then using that quantitative methodology that I talked about before, project how many females out of 100 would get pregnant. So for example, if 85 females were having sex over the course of the year and using no birth control methods, 85% of them are projected to get pregnant. And that was interesting information that they like to learn. Next was their turn to wrap up. They input some information about their goals, and this got fed to them later on in a series of text messages. So we didn't do a lot of texting. We just did once a week to reinforce some of the concepts of the app itself, and then also link them to a website, which was a repository, again, of evidence-based websites. So really good things that were out there, and some local clinics. And lastly, the last few phases are really thinking about phase 4, which is the coding and the testing and really making sure that your product works in the real world. And then it was time to actually deploy it. So we did this in a pilot RCT, but there are many ways to actually deploy the app. So just published a few months ago was our randomized controlled trial of the Dr. Eric intervention. This was a prospective, single-blinded, parallel group RCT that spanned both the adult and PDR, looking at sexual active adolescent and young adult males aged 14 to 21. Here, those randomized to the intervention group got the app and these text messages, while the control group got standard of care. And again, we showed it was feasible. We showed it was acceptable. There was pretty high adoption, although we had these live office hours that they could text into that nobody engaged with. And the fidelity was pretty good as well. So our primary outcome was actually condom use, which we define as a proportion. So the denominator was total sexual encounters over the past month, with the numerator being total sexual encounters over the past month with a condom. And we showed that even when controlling for age and baseline condom use, those in the intervention group were more than three times more likely to use a condom over the past months than those in the control. Although that difference did go away by 13 weeks. Not surprisingly, those were consistent condom users at the beginning were the most likely to be consistent condom users at the end. So this was the first ED-based sexual health intervention to increase condom use. And now we're deciding how to pair this with an intervention that can help sustain change. But I will say that we were left with this model that we also just published last year that can really be used as a blueprint for both inside and outside the ER as a method of what you can think about when you want to design a digital health intervention. Okay, perfect timing. So talked about Erica and we've talked about Eric. So now I can finally talk about Sticker. And obviously all my interventions really start with a good story. So 2020, end of 2020, COVID was still around, just still around. And I was working in the ER and we had a baby with possible TB. So we did a PEDS ID consult. And in walks this guy, Jason Zucker, who I had heard about, who was a PEDS and ID attending, who I knew in the outpatient world really was interested in sexual health. And he kind of looked at me and I looked at him and I was like, oh, I've heard about you. And he's like, I've heard about you. And I'm like, we should do something together. So because we both knew that screening for STIs is essential to reversing the STI and HIV epidemic in the US. So about 1 in 5 people have an STI, with 2 of the most common being chlamydia and gonorrhea, and nearly half of these occurring in adolescents and young adults aged 15 to 24. So we sometimes test for STIs in the ER, right? Like we do it when it's clinically indicated. Positivity rates can range from 7 to 21%, depending on your symptomatology. That's urine testing. I want to ask everyone in the room, when was the last time you tested for oral or rectal STIs? I can't see your faces, but I'm going to guess that it's not very often. And unfortunately, failure to perform extragenital STI screening contributes to the propagation of disease. In fact, in outpatient clinics, extragenital STIs were as high as 77% in females. Now, this is STI clinics, and 22% in men who have sex with men. And up to half of these STIs would be missed if extragenital testing was not performed. In the ED, extragenital testing is rarely performed, with less than 5% of patients presenting with a complaint being tested. So we wanted to create something called STICKER. So STICKER stands for STI Check in the ER. It's an evidence-based digital patient decision aid that facilitates equitable oral, urinary, and rectal STI testing using a shared decision-making approach among adolescent and young adult patients. This time we were building a patient decision aid, and there are guidelines on how you were supposed to do this that we wanted to adhere to. So we adopted their algorithm and kind of combined it with our 5D model that we had before. So the first thing we wanted to do was define the health condition and target audience. And I think over the last half hour, I feel like I kind of explained that we kind of already proved that adolescent and young adults were receptive to ED-based interventions, and that extragenital testing was rare, and that adolescents we also knew in the ER were often using the ER as either their primary source of care or their frequent source of care. So we created this steering committee with ED physicians, implementation scientists, infectious disease, and adolescent experts to really help us guide the intervention. And we also partnered with the local HIV Prevention Community Advisory Board, which not only had youth, but also had parents from the local community. And then we started to think about our theoretical framework. So our conceptual model was built around shared decision-making. A patient would engage with the app around STI testing, thereby increasing their knowledge and selecting an option that most align with their values and preferences. This would lead to decreased decisional conflict and increased trust in their provider, which hopefully in turn would then lead to an increase in STI testing when indicated. So hopefully some of this sounds familiar. I'm not going to go over a ton of it again, but with our first design session, we partnered with a digital design agency and a team of user experience and user interface experts. And in workshop 1, we focused on understanding the user, capturing their current experience and defining the target population to generate these key audience attributes and develop, like I said before, these personas of different people who might come to the ER and interface with the app. A second workshop focused on capturing the existing experience in STI testing in the ED. So we leveraged some ethnographic methods. So observations, we even sent photos of the ED to the design agency, and we developed these journey maps showing key steps in the process and highlighting when and where sticker might be applied during the ED visit. And then these personas and journey maps were refined for workshop 3. The third workshop really focused on the ideation of the ideal experience, which we like to call like the happy path. And it simplified the journey map, considering each person's preferences and mindset to envision the best possible experience that they can have with this STI testing tool. In order to test our assumptions, we built this low fidelity prototype using the tool Figma and kind of designed the content over the PowerPoint like I talked about before. So at this point in time, we had really kind of gone through in year 1 of an R21, the design and development. Thinking about our health condition and target audience, we have our steering group and these workshops. And next it was time to do our alpha and beta testing. So over here in this orange area, you can see that taking this low fidelity prototype, we started going to the user, our steering group, and we also talked about to health providers because it was built within the ED experience and their input was very important. They were also going to interact with it a little bit, so we really wanted their feedback. And we did it again over here. So for our patients, we spoke to about 20 patients with some of the key themes being, I'm open to STI testing. Rarely does anyone offer it to me. I want to be involved in the decision of why I want to be tested for an STI. Privacy is important to me, especially when collecting information on sensitive topics like sexual health. And in the providers, workload is reduced if my patients interact with Sticker before my assessment. Sticker being EMR agnostic, this was very interesting to us, allows patients to feel like their data is private. And this is what we actually ended up doing. I'll show you what Sticker looks like before, but it lives on the patient's phone. It became a web-based app that does not on purpose interact with the EMR. So it could live in any ED across the country, regardless of what that EMR is. And so we don't have to go through the hoops of actually putting it in. Sticker eliminates the potentially uncomfortable verbal conversation about sexual behaviors between a provider and patient. So Sticker asks really sensitive questions that can be very uncomfortable for some providers to ask. It is also important to test for HIV and syphilis, which would require blood testing. So in this version of Sticker, we were really focusing on just oral, rectal, and urinary gonorrhea and chlamydia. And so this was important to note that there was an interest in actually making it broader. So Sticker starts by the patient coming in and actually scanning a sticker, which is their QR code, and then up pops on their phone this web-based app. So the opening page appears, and then a prompt comes up, reminding them that the goal of this is to be non-judgmental, private, and fast. Goes back to the landing page where they can learn a little bit more about STIs, ultimately trying to even the playing field of baseline sexual health education. Next is a sexual health survey, which is adopted from I Want the Kit, which is a validated survey that helps us risk stratify patients for high, medium, or low need for oral, rectal, or urinary gonorrhea and chlamydia testing. The results are then shown with some explanations. For this patient is deemed needing 3-site testing. And then it goes through each of the different sites. So for this patient, oral testing is recommended. And so we go through a little bit about what that looks like, and then ultimately they could decide if they want to be tested today or not. Sometimes a patient might be at medium risk or middle risk for an STI. And then they go through a series of shared decision-making modules that allows them to slide this preference bar based on their values and preferences around testing either today or follow up with their primary care provider at a later date. Before finishing, a prompt appears reminding them that STIs might have no symptoms, and the app ends with a screen to show their provider. And the provider knows that when they press their finger on the bottom button, their testing recommendations and their desire to have testing then appears, with the goal to ultimately lead to a shared decision-making conversation between the patient and the provider. Of course, we needed to beta test this, right? So this was the second part of the grant where we conducted an RCT. In this RCT, we actually randomized providers to either be trained in the Sticker app or not, or just providing usual care. And these were providers that span both the adult and pediatric emergency department to enroll 140 patients. We collected data in a various number of ways. And our primary efficacy outcome was any STI testing with different types of STI testing as secondary. And we did show significant differences. So we doubled any STI testing, we doubled GU testing. There was more than 4 times more pharyngeal testing with slight increases in HIV and syphilis, but nothing significant. We also showed more, the purple being the intervention. More often did they discussed STI testing. More often did they want testing, and statistically significant, they often more recommended their ER after their visit. And I think this speaks to adolescents and young adults really entering this phase where this is kind of the first time that they're independent, that they're on their own. Maybe their parent isn't with them, and feeling heard and feeling listened to was something that they really valued. So what's the next for Sticker? I think it's hopefully pretty obvious that we need to start thinking about HIV and syphilis. So maternal and neonatal syphilis are rising. Syphilis screening in the ED remains infrequent despite a 61% increase over the last few years and a 106% increase in congenital syphilis. Kim Stanford's doing some really awesome work in Chicago around this. And in her routine ED screen, she did some ED screening and found that 91% of patients were actually asymptomatic. And in 2022, HIV rates were about 32,000. The largest number of HIV infections occurred amongst young people, and it's estimated that about 13% don't even know that they have it, and fewer than 1% of ED patients are routinely screened. Of the 32,000, 67% were gay and bisexual men. These are complicated questions to ask in the ER, particularly if that's not why you're there. And I think the great part about sticker is it really does it for you. So our next step for sticker are really to think about adding HIV and syphilis. We just submitted an R01 last month. Think about this as an implementation trial across multiple unique EDs. All right, so we have a few extra minutes, which is great. So I can just briefly touch base about what other people are doing, not in the sexual health world. And then before you ask me, I'll just sprinkle in a little bit of cool stuff that's recently been published thinking about AI. So this was an interesting RCT that was published in JAMA Open about 2 years ago, in which the authors randomized about 800 women and men who identified as Latino with unhealthy drinking behavior. So this really focuses on alcohol use. Those in the intervention group received this automated bilingual computerized alcohol screening and intervention. And it really was an SBRT. And if you don't know what that is, that's a short behavioral intervention with referral and treatment. And in that, it had the audit and a brief negotiation interview focusing on raising the subject, providing feedback, enhancing motivation, negotiating advice. It was administered at the patient's bedside and ended with this kind of cool printed, personalized alcohol use reduction plan. And results showed that those in the intervention group at 12 months were more likely to significantly decrease their number of binge drinking. So I thought that was interesting. Here's another one. This is an mHealth theory-based 2x2x2 factorial trial thinking about hypertension out of Flint, Michigan. I think this is a really cool study design. Sometimes you have a lot of different ideas and you don't know the special sauce of, is it too, you don't want to put everything, all 6 parts of your package in one, but how can you test them individually or together to think about what is the right combination? So this was cool because it had these 3 different parts. So one was this facilitated primary care appointment scheduling and transportation. So they either did it or they didn't. The second one was self-measured blood pressure monitoring and feedback. So these were sent text message reminders to check their home blood pressure and then send that information in. And then these healthy behavior text messages. So they really talked about salt reduction, fruit and vegetable intake. And then they sent these personalized messages to them based on what their blood pressure was, kind of within that loop. The primary outcome was changed systolic blood pressure from baseline to 12 months. And what was interesting, of the 200 people they put in all the different 8 groups, they declined their blood pressure after 6 months. And there was actually no difference between these different groups, showing that something was better than nothing, but something that you didn't need everything to actually show success. One other one that I was a part of through the PCAR network, which was mentioned before, is we developed another CASI, but this was for suicide youth. This was across 13 to 14 EDs. We enrolled over 10,000 adolescents, really thinking about giving them these large baseline assessments to first derive this CASI, so a shortest set of questions to help screen them for suicide risk in order to risk stratify them for low, moderate, or high. We gave them all these different questions and ultimately developed this CASI, which is a combination of multidimensional item response theory model and a prediction model. And it had a mean of around 11 questions. It only took 1 to 2 minutes for administration. And here you can see that the derivation of the rule actually showed pretty good sensitivity. And so there's some data out there now trying to see if we can do this in the real world. I think what's great about this is questions were tailored to the severity or risk of the adolescents. Different items will be presented based on the patient, and it takes the ED provider out of it, right? So you don't have to have the nurse or the doctor asking these screening questions, but the Cassie does it for you. Okay, and the last just few minutes, AI. So last year, Anna published a really cool paper where the authors explore the transformative potential of artificial intelligence in emergency medicine, really thinking about these three overlapping stages of AI development. So mapping, really thinking about our proof of concept studies, feasibility, measuring, then really looking at the real world effectiveness of these AI applications, and then management, actually deploying them in clinical settings on an ongoing basis. They also talk about some of the practical challenges, implementation, and legal considerations. And they give you a really long list of different examples of stuff that's happening. There's a table here that I'm just going to briefly mention that talks about some really cool things, right? So diagnosing pulmonary embolus on EKG, risk stratifying for a traumatic brain injury, appendicitis, pulmonary embolus, and chest pain. How do we predict who might have positive urine cultures, who might have sepsis, who might have clinical deterioration? And then also, how do we help triage? Is there a way that we can predict hospital admission or disposition? And how can we identify critical illness or patients with even low severity of disease? And lastly, I'm just going to talk about this. This paper also came out in the last year in the American Journal of Emergency Medicine. It's important to note that some of these products actually do need to go into FDA review that meet the definition of a medical device, which is defined as a products that are intended for use in the diagnostic or cure, mitigation, treatment, or prevention of disease or other conditions. Here you can see that these products span many fields. A lot of them really think about radiology, how we can perfect kind of the diagnostic ability of ultrasound, CT, EKG, MRI. I'll just three little examples for something called EpiMonitor. I don't have any stock in any of these companies. I just thought these were cool. These are thinking about how we can use seizure monitoring. So a wearable wrist device that is continuously analyzed to understand general tonic-clonic seizures, or this Brainomex triage stroke, which checks and triages large vessel occlusions and intracranial hemorrhage, or our ability to detect and triage central pulmonary embolus. Okay, I'm done. So if I can leave you with any advice, I've learned a lot about technology, but I think technology alone is really never enough. I believe that the future of digital intervention will be a combination of the work that we do every day and the world of technology. And I hope that this talk maybe inspired a few of you in the audience, maybe residents or junior attendings or really anybody, to think about the ways that you can use technology in the care of your patients, or ways that you can improve the health of your patients today using technology in your future.
The Always On EM Podcast.
Emergency Medicine Grand Rounds.